All right, so we're doing hematology today. So hematology, oncology. So we're doing some talking about the RBCs, the white blood cells, and the platelets, and that's kind of the general framework you want to kind of consider. So we'll start with RBCs, right, and talk about some RBC disorders. We'll talk about platelets and some platelet disorders, and finally white blood cells and some white blood cell disorders. All right, those are our three main contenders. And then we'll end it with chemotherapy. I was thinking of starting the chemotherapy because usually you're more bushy-eyed and bright-tailed, what's the word, when you are in the morning. But we'll finish that. We'll get a good break. We'll get caffeinated before we start chemotherapy, all right? Because it's probably, I feel it's a little worse than the antibiotics because it's based on research. It's not based on like, oh, that makes sense. It's gram-negative. No, so it's based on just like, oh, let's try this one. Let's try that one. All right? But we'll try to organize as best we can. Okay? So I have to instill it into you somehow, into your brains for the NCLEX. So this is your day. All right, for chemotherapy. Okay? All right, so hematological nursing. All right, so we're going to start with RBCs, and here are some of our RBC disorders. Anyways, two little RBCs is anemia, and there's several anemias out there. We're going to focus on these big ones here. All right, so iron deficiency anemia, we got B12 deficiency, folic acid deficiency, and finally sickle cell anemia. All right, and anemia of chronic disease, which is what renal patients get. That's usually, and patients that have inflammatory processes like autoimmune processes. Those are going to be those are iron deficiency anemias. That's like a subtype. Okay, so we're talking about just this little bit right up here. Okay, so RBCs are they have they start at a stem cell, right? So there's a stem cell that sits inside the bone marrow, and it differentiates. It changes shape until it becomes either a white blood cell or a platelet overlord or a RBC. Okay, and we'll talk about those. So our first section is RBCs. Okay, so we'll talk about hemoglobin a lot because what is hemoglobin made of? Heme is a good answer. Heme and iron. Okay, so the iron piece is what obviously can happen with iron deficiency anemia, right? We don't have enough iron, we can't make enough RBCs. Okay, also the RBCs need to divide, and for a cell to divide, it needs first to replicate its DNA, right? So you need two sets of DNA. That's mitosis, right? Or replication first, actually, and then it divides. The whole cell divides, right? With mitosis. So you need to be able to divide your cells and make new copies of your DNA. And if you don't have the right amount of materials, then you're not gonna be able to produce RBCs, and you'll get anemic, right? So that's usually what B12 and folate are all about. Whereas iron deficiency is you don't have enough building blocks to make the RBCs in the first place. Okay, here's an example of some RBCs. Let's see here if this works.
A friend asked me to do some microphotography of her blood. When I put the sample under the microscope, I was just astounded at how many red blood cells there were. Without any dilution or smearing, they really do behave like a body tissue that just happens to be a liquid. I added some saline solution to get a good look at individual red blood cells. Under phase contrast microscopy, you can really see their textbook jelly donut shape. Zoomed in a little more and you can see them stacking together. Bonus points if you can find a white blood cell.
All right, so white blood cells are few and far between, but RBCs being the most common. Okay, so an RBC, it's AKA an erythrocyte. All right, you can see this is 1 cubic centimeter, right? Sorry, cubic millimeter, right there on a penny, and in that cubic millimeter there are 5 million RBCs, right? So in your whole body you have trillions of RBCs. It's a crazy amount that are being circulating through your whole body, and then you're making 2 million every second, and 2 million are dying every second. 2 million, all right? It's a crazy amount of RBCs. Obviously, if that production tones down, you're going to get anemic, right? So males and females have a different amount due to muscle mass and menses, but we're going to talk about different, we talked about H&Hs and Med-Surg 1, right? What's a normal hemoglobin? Back from Med-Surg 1. 15-ish, right? And then that relates to the what? By a 3x relationship. Relates to the hematocrit, right? So about 45% would be 3 times 15, right? So hemoglobin is about 15. And again, it varies male and female, and it's a 3x relationship, okay? So plasma is the other portion of our blood. The biggest portion of our blood is our RBCs right there, right? It's 45% of our blood. If you centrifuge it out, you let them all sit at the bottom, that's going to get you a hematocrit, a percentage of RBCs to the whole deal, okay? So also in this little buffy coat right here, that's where you have your white blood cells and your other pieces of the puzzle, right? That we'll be talking about. We'll talk about platelets and we'll talk about white blood cells, I promise, okay? So disorders of too much RBCs, you have too much hemoglobin, too much RBCs, usually the hemoglobin greater than 18. You could use hematocrit, right? 18 times 3 is what? 44, no? 54, right? So greater than 54% hematocrit, technically you have polycythemia, you have too many RBCs, right? That's usually due to chronic hypoxia. What disease state usually gets chronic hypoxia? A certain version of COPD, right? Chronic bronchitis patients get chronic hypoxia. And then there could be genetic reasons why you'd have an elevated RBC count as well, right? But we'll be focusing again on the too little RBCs, anemia, right? And there's many types out there. We're going to focus on the ones talked on the previous slide, all right? And we need labs to tell us which one's which, all right? It'll tell us if someone is iron deficient. Obviously, their iron count will be low, and that will clue you in. It might be iron deficiency anemia, okay? So they have about a 90 to 120 day life cycle. So 120 days is 3 months, right? Or 3 to 4 months. And when they're destroyed prematurely, right, then the younger RBCs will be called by the Red Army to come out and go to war, all right? So those are your reticulocytes right there, right? So your reticulocytes or your RBCs can be in circulation. Yes? No sound on Zoom. Yeah, I'm going to have to look at it at the break. I don't know why it's not displaying on Zoom, but I'll have to display the recording later for PowerPoint. The PowerPoint's working for sure. All right, so again, we have reticulocytes and we have RBCs, or erythrocytes technically is the most mature RBC. And either one of these are really the functional RBCs. They're the ones that will carry oxygen, right, which is our primary job here, right, to transport oxygen, also transport CO2, right? CO2 is going to the lungs to deposit the CO2 so you can exhale it, right? Otherwise you get respiratory acidosis and ABG stuff. And then you pick up oxygen from your lungs, hopefully, right? And transport that to the tissues. So we have erythrocytes and reticulocytes. The only reason why you have reticulocytes would be going up was because your RBCs are dying, right? They're being hemolyzed. They are being destroyed, right? And sometimes, again, after 4 months, after 120 days, you're making 2 million every second, and 2 million are dying every second. Those 2 million that are dying are what are called senescent, right? Senescent just is a fancy word for saying old, all right? So you have old RBCs getting destroyed all the time. And I think on the next slide, we describe what that looks like, right? They are recycled. Basically, we're going to recycle the iron, and we're going to recycle the heme. If we don't recycle it, the heme then goes into the bile, right, as bilirubin. So the other feature of an RBC is that it is anucleic. There's no nucleic acids in it. What's a nucleic acid? That's DNA and RNA, right? DNA and RNA sits inside the nucleus of the cell, and the RBC in its lifespan, it's going to enucleate. So over here, it enucleates. Just before it is ready for prime time, it's going to enucleate, spit out its nucleus, right? It doesn't participate in any kind of cell division or protein synthesis or anything. It has what it needs for 4 months, right? And it's good to go, okay? So the enucleate, so we got a stem cell up top, and a stem cell can divide into the white blood cell line. It can divide into the platelet cell line. And right here, we're talking about the RBC cell line, right? A stem cell is where everything stems from, right? So we have different versions, and then it enucleates, and then we get a reticulocyte or a erythrocyte, right? Oh, I'm trying to circle in red. It doesn't like red. Nope, not. Try again. All right, there we go. All right, so erythrocyte or reticulocyte. Okay, so what else? So then your reticulocyte is the young version. The erythrocyte is our mature version, mature. All right, so the life cycle. All right, so RBC building blocks. So what do you need to make an RBC? You need erythropoietin. All right. So if you're deficient in erythropoietin, you're not going to make RBCs, right? RBC, where does erythropoietin come from? It comes from the kidneys, right? So when you have kidney disease, that's going to cause a lack of erythropoietin. As we'll find out, inflammation will stimulate a hormone called hepcidin. And hepcidin actually inhibits erythropoietin. Okay, so when you have a chronic inflammatory process, you have an autoimmune disease, you have lupus, you have anything that's chronic and inflammatory like Crohn's or ulcerative colitis, these things are chronically inflammatory. When you have inflammation, it stimulates hepcidin, and hepcidin will inhibit erythropoietin. So they have what is called anemia of chronic disease because of that, right? And hepcidin actually inhibits iron absorption from the gut. So you get iron deficiency anemia with inflammation, chronic inflammation, right? And then iron. You need iron to make RBCs. So if you don't have iron and you have low RBCs, you have iron deficiency anemia, right? And then we have B12 and folate. B12 and folate are kind of grouped together. They have very similar symptoms. They have very similar pathways. Basically, you're not making DNA or RNA. You need B12 and folate to make DNA and RNA, and therefore your RBCs can't divide as much as they like to because they want to be able to, replicate their DNA, right? If they don't have the resources, they're going to lead to an anemic state, right? So we have B12 deficiency anemia, and there's a variation of B12 deficiency anemia called pernicious anemia. Pernicious anemia is sometimes erroneously called B12 deficiency anemia, but it's a type of B12. So just like you have, you have, what's a good one to say? You have hypertension, and then you have something where you have a tumor on your adrenal gland that secretes norepinephrine all the time. So that tumor, pheochromocytoma, is not always hypertension, right? That's just a subset of that symptom, right? So it's a type of B12 deficiency. All right, what else? So you got to, so what is pernicious anemia? So we'll just kind of introduce it here. We'll talk about it more later. That's just where you are attacking the intrinsic factor, which is necessary for B12 absorption. So if we can't absorb B12 in the gut, right, in the terminal ileum there, then the reason why you couldn't absorb B12, A, you didn't intake it, right? You didn't put it in your body. Or B, you had a problem with intrinsic factor. And we'll talk about where intrinsic factor plays a role. This is like an autoimmune situation where the intrinsic factor is being attacked, and therefore you need intrinsic factor to absorb B12. All right, so that's B12 deficiency anemia. Then we have B9 deficiency anemia. So B9 is folic acid or folate anemia. All right, folic acid deficiency anemia is we don't have enough folate intake. Okay, and there's something called aplastic anemia. That's just bone marrow suppression. Aplastic technically is where everything is gone, right? So you have no bone marrow, and what comes from the bone marrow? RBCs, platelets, and white blood cells, right? That can happen with alcohol, all kinds of meds, but especially chemotherapy meds, and we'll point out those ones that are really high likelihood to cause a bone marrow suppression. Okay, so you might not have the building blocks, so this will change your shape and size of your RBCs. So you can change what's called the mean corpuscular volume. So our corpuscle is our RBC, right? That's our corpuscle right there. And that can get bigger or smaller, depending on whether we have B12 deficiency or iron deficiency or B9 deficiency, right? So we'll point that out. So they can either be big, macrocytic, or small, microcytic. So cytic meaning cell, right? And then we have red cell distribution and width. RDW is another lab we look at, and that will tell you what the percentage of variation there is, right? If there's no variation, everybody is 6 feet, 150 pounds, you have very, very little variation, right? But if you have some people that are chunkier, some people that are shorter, you're going to have more variation in your statistics, right? So RDW is the red cell distribution of width, right? So here's a narrow distribution. It means there's not much variety. But when we start pumping out fat RBCs or start pumping out really, really small RBCs or microcytic RBCs, then the variation is going to increase, right? So that's an increased RDW when you have variability. And that's not good. You want all your RBCs looking the same because usually they function when they're all the same, right? They are usually not have an error in their production. Okay, And then we got mean corpuscular hemoglobin concentration. That's just really kind of useful for iron, right? When you're iron deficient, you're not going to be able to make hemoglobin. Therefore, the amount of hemoglobin average between each RBC is going to be low, okay? And the RBCs are broken down, again, after 120 days, at least, at the most. And they are broken down how? Well, we have macrophages that are just floating through the bloodstream, waiting to eat an RBC. Look how metal that is, right? So that guy's just eating the RBC, all right? So he eats old people, old RBCs. That's his job in life. He just goes around and he erythrophagocytizes, all right? That's a good thing to put on LinkedIn, all right? So that is, he goes around and eats old RBCs because then they don't become functional and, right, it's expensive. No, I'm kidding. So it's an issue when we have older RBCs. They are not going to be functional, all right? So that's one place where we can get it. It's just in the highway of the vascular system, or the RBCs all filter through the spleen, right? And the spleen its job is it's a big Brita filter for all the blood. All your blood goes through the Brita filter or spleen, and then returns back to the heart, right? All the blood goes through there, and the spleen is just one huge lymph node. And what's inside lymph nodes? Is lymph cells is a good answer, right? Lymphocytes. Those are B cells and T cells. And we talked about B cells and T cells with HIV, right? HIV attacks which one? The B cells or T cells? The T cells, right? Those are your natural killer cells. That's what kind of organizes the whole situation. B cells, we talked about the HBV, right? B cells secrete antibodies, right? So it makes sense that these guys should be kind of centrally located, right? Either in the spleen, the biggest lymph node of them all, or other lymph nodes. Where do you have lymph nodes in your body? They're in the axilla, the neck, the groin. Those are the most common locations for these, right? So these guys are just there, and they are waiting for some kind of not immune, but it's something that's foreign, right, to filter on through, and then they will, analyze it and develop antibodies against it or attack it, right? But the other thing they do is kill incoming RBCs. And RBCs, they don't look right. They don't look right. The RBCs are brutal. They are going to make sure, hey, you're too chunky. Come here. And they're going to eat it, and they're going to destroy it, right? If it's too small, do the same thing. If they are sickle-shaped, they're going to do the same thing, and they are going to hemolyze them. They're going to eat them and phagocytize them, right? Phagocytize means to eat, right? So our RBCs can just hemolyze spontaneously. There's certain situations where your RBCs just hemolyze, autoimmune situations. We'll talk about some leukemias where that happens. But usually they hemolyze once they're 120 days old, and either with our macrophage involved. And basically you get the different components. You get the heme component, and you get the iron component, right? And the iron hopefully gets recycled, right? That way you don't have to intake more iron, because as we'll find out, it's difficult to absorb iron. Okay, so the hemoglobin, what happens to the hemoglobin? That gets bound by what's called haptoglobin. And the reason why I pointed out is because haptoglobin is one of the labs we can do for hemolysis. If we are hemolyzing RBCs left and right, we're going to be using up all of our haptoglobin. Our haptoglobin is like Velcro. It's going to attach to hemoglobin that's circulating, free hemoglobin, not hemoglobin that's inside of RBCs. But once RBCs have spilled all their beans or all their hemoglobin, your haptoglobin is going to sop it up like a sponge, and then it's going to make its way to the liver, and it's going to turn it into bilirubin, right? And we know the bilirubin story from gallbladder and liver, right? That's going to then exit via the bile into the gut, okay? But we need the gut to absorb our iron, to our B12, our folate, and other nutrients to allow us to make RBCs, right? And once we make the RBCs, they get old. How old do they get? About 120 days. And then we are on our way to getting, we are then back to square one, where we are breaking apart our RBC, and we are starting the whole cycle over. Okay, does that make sense? When your haptoglobin's low, what does that mean is going on? That means there might be hemolysis happening. RBCs are getting destroyed. At any one time, they're in use, and they are there, and they are doing their job. But when there's excess amount, then your haptoglobin is going to start to go down. Excess amount of hemolysis. Their job is to go to work and sop up the hemoglobin all day long. 2 million RBCs per what? Per second, right? That's what they're sopping up. All right, so anemia signs and symptoms. So what happens when you don't have RBCs? What do RBCs function again? to carry O2 to the tissues and take away CO2, right? About 60% of the CO2 goes away from the tissues, right? But via the help of RBCs. So every anemia has the same symptoms. So we can copy and paste a lot of these symptoms to every single anemia, right? So if you don't have RBCs, you don't have O2 delivery. And poor O2 delivery to the tissues, it's not going to get, it thinks it's the same story as low blood flow to the tissues, right? So guess what? SNS is going to fire off. So what's the SNS symptoms? What are some SNS symptoms? You got some tachycardia. What else? Tachypnea, pupil dilation, no, diaphoresis, right? Those increased respiratory rate. These are signs of poor oxygen delivery to my tissues. It's not because my heart has failed or because I have low blood pressure. I have great blood pressure. My heart is great. And my heart's actually going to beat faster because the SNS is going, because you're not getting oxygen to your tissues, right? So we get a SNS response here. We get a hypoxic state, right? We get SNS stimulation. We get tachycardia, tachypnea, some palpitations. That's just tachycardia, right? But the patient might complain of that. Then I'd come to the office and say, oh, I got some tachycardia. Maybe their Apple Watch told them, but that's a symptom, right? They feel like their heart's beating fast all the time. And it will be. It's hyperdynamic. The heart is actually working overtime, right? It's circulating blood that's like super thin like water. And it's going to be working overtime. The blood is actually less viscous, so it's easier to do that. But you can't do that forever, especially if you're older, because then the heart's going to give out, right? And you will die from an MI if you have a anemia, especially if your hemoglobin starts getting less than 5, right? So it's really hard to die from anemia, but when your hemoglobin starts getting less than 5, that's when you're high risk for a myocardial infarction or a heart attack, right? Also, you get low O2 state to your brain, right? It's the same thing, getting low blood flow to your brain, low O2 to your brain. What happens? You get dizzy, confused. What else? Lightheaded. You get syncopal, right? So syncopal meaning that you are what? You syncopize. If someone syncopizes, what do? Are they in a rap battle? No, syncopizing means they fell over, right? They fainted, right? So they faint and, like, big deal, they fainted. They fainted in bed on a nice cushy surface. Well, that doesn't always happen. Sometimes they're driving down Sierra Highway. Sometimes they are, they're walking down their stairs and they become syncopal, right? They get up too fast and they just fall over, right? And they die from the fall, not from the actual anemia in that case, right? So dyspnea on exertion, obviously you have low O2 to your tissues. Your muscles are going to get fatigued. So fatigue, dyspnea on exertion, they can't walk very far and because they don't have enough oxygen circulating around. They might have plenty of oxygen, but the 98% of your oxygen has to be carried by RBCs, right? So what else? So we got lightheaded, confusion, dyspnea on exertion, fatigue, hypoxic state, and our complications there, right? So we talked about there's microcytic anemias and there's macrocytic anemias, and we'll go dive into those. But iron deficiency anemia is the only microcytic you have to know, and of course anemia of chronic disease is a subset of that. And then we have macrocytic anemias. That's folate deficiency, B12 deficiency. You get macrocytic, and we'll explain why that is. You don't have to listen to me tell you the reason why, but I'm going to let you know so that you can remember this. Otherwise, you're just going to intellectually vomit it on the test, and then you're not going to know it for the rest of your life. That's cool, right? But otherwise, we're trying to give you the theory behind why you have all these different symptoms. Okay, and then sickle cell disease is another anemia we'll talk about, and that one's actually normocytic. All right, meaning it's normal size, but they sickle during certain situations. Okay, and one of these, well, actually, I should just highlight them right now, are folic acid and B12 deficiency anemias. They get macrocytic, and they're going to get chewed up by the spleen. And you're going to have excess chewed up RBCs, and you have excess chewed up RBCs, you have excess heme, and excess heme gets converted into what? Into bilirubin, right? So you can start getting yellow when you have hemolytic anemias, right? You get yellow skin. You could get yellow eyes too, change in stool colors. These are really with hemolytic anemias. Sickle cell is another example of hemolytic anemia. Okay, so your cells are really, really big with macrocytic anemias, and it's too big for the spleen's liking, and it starts chewing them and eating them and breaking them apart. Okay, also conjunctival paleness, and there's some other unique symptoms we'll point out. But you have low O2 to your tissues, you're going to be pale. You're going to be pallorous. You have pallor, meaning you're just white as a sheet. Okay. All right. Any questions on the symptoms of anemia?